Good morning. This is Dr. Murphy with the Department of Anesthesiology at the University of Kentucky in Lexington, Kentucky. And this is part 2 of my series of 2 podcasts on heart failure. And this particular podcast is on the anesthetic management of heart failure and related issues. Primary reference for this podcast is the chapter from Stelting's Anesthesia and Coexisting Disease as given to you in the first podcast. And the primary educational objective of this podcast is to allow you to discuss the anesthetic management of patients with heart failure. So, anesthetic management, typically divided into preoperative, intraoperative, and postoperative. Preoperative. Typically, the preoperative management of patients includes management of medications, perhaps specifically prescribing the time of certain medications or the omission of other medications, and also the review of the symptoms or the history of the patient, and reviewing and demonstrating physical findings and reviewing the laboratory studies of patients. So this applies as well to heart failure patients. Intraoperative management is pretty straightforward, could involve some specific monitoring, and it's of interest that the chapters that you may read regarding heart failure and anesthetic management are not all that directive. They do perhaps require you to rely upon your own knowledge and experience. So first off, I'll quote the recommendation that perhaps any anesthesia, but perhaps in reduced dosages, would be appropriate for a heart failure patient. It's also recommended that perhaps opioids or an opioid-based anesthetic might be appropriate for a heart failure patient. Given the back pressure on the lungs from elevated left ventricular and diastolic pressure, perhaps PEEP is recommended management of a patient with heart failure. Becoming more invasive, perhaps a pulmonary artery catheter may be indicated. Of course, you can follow ASA guidelines on the use of pulmonary artery catheters and tailor them to your institution. Perhaps transesophageal echocardiography is indicated in the management of intraoperative care for patients with heart failure. Again, following published guidelines on the use of TE would guide you in this way. Not every patient who has heart failure needs to have a transesophageal echocardiography performed intraoperatively. Perhaps instead of a general anesthetic, the use of regional anesthesia would be most appropriate. And in general, the safest anesthesia is the least anesthesia without stressing the patient. If a procedure can be safely done under local anesthesia, either by infiltration or by nerve block, perhaps this would be preferable in somebody with reduced cardiac reserve and heart failure, even if it's he or she is in optimum condition. I ran across a statement that practitioners should be aware that a reduction in systemic vascular resistance could cause hypotension. To which I reply, really, it's not really rocket science. Unfortunately, this is the level to which your textbooks provide direction in the management of patients with heart failure. And at least for patients who are undergoing heart transplant, I ran across a recommendation that strict aseptic technique should be practiced. So, if any anesthesia, but perhaps in reduced doses, just is appropriate, you should remember that compensatory mechanisms may include increased sympathetic tone, so that any central nervous system depressant, even opioids, will have the potential to decrease cardiac performance, or at least cause hypotension. If there are specific recommendations that can be made regarding the intraoperative anesthetic management of patients with cardiomyopathies, it could be that you should be cautious, careful, and vigilant with the use of intrathoracic pressure and pneumoperitoneum. You should be aware that that dynamic left ventricular outflow tract obstruction can occur with hypertrophic cardiomyopathy, and that myocardial oxygen demand may exceed supply in HOCM. Now, the management of dilated cardiomyopathy is more or less by the book, and patients who have dilated ventricles that are underperforming may well require some kind of inotropic support, and classically dobutamine or low-dose epinephrine or milrinone with norepinephrine are all quite reasonable choices. Of course, some of these medications should be given centrally for safety. Now, peripartum cardiomyopathy requires planning, and requires planning on the part of all of the caregivers. And I'll summarize that the management of restrictive cardiomyopathy is quite similar to that of a pericardial tamponade. In other words, full, fast, and tight. Now, LVADs, intraoperatively, they already have mechanical support. It has been observed that that the HeartMate 2 is being replaced or overtaken by Heartware, a different technology, but still an LVAD. All LVADs are not cared for by cardiac anesthesiologists. The increasing number of patients with LVADs means that general anesthesiologists will have to become somewhat familiar with the management of these patients. This is a review article written by Dr. Hessel, published in 2014, and would be a good place to begin your review for of the management with of patients with implanted LVADs for non-cardiac surgery. One of the things that I've come to know and understand is that the LVAD coordinator or the LVAD nurse often is a very, very good resource intraoperatively, and at the University of Kentucky it's normal practice for a patient with an LVAD to be accompanied by the LVAD coordinator. And the feedback that you get from this person regarding the hemodynamic condition of the patient is quite useful and important. Not every patient who is undergoing an anesthetic or some form of sedation for a non-cardiac procedure requires an arterial line. However, if an arterial line is indicated, the LVAD coordinator can be helpful in developing a pulsatile patient, a patient with a bit of a pulse, so that your arterial line is more easily done. Of course, in this day and age, visualizing a radial artery by ultrasound and cannulating it under direct vision and guidance is pretty routine as well. So, just to summarize, the anesthetic management of LVADs from Dr. Hessel's review article, it's important that all anesthesiologists be aware of the special needs of patients with ventricular assist devices requiring non-cardiac surgery. And as I alluded to in the last slide, knowing the patient's volume status and being able to increase intravascular volume are both important in the management of these patients intraoperatively. Here's another article which summarizes the perioperative management of patients with left ventricular assist devices undergoing non-cardiac surgery, and may well be worth your time to review. Yet another article from about the same time indicates that this is a growing concern among anesthesiologists, and while this is published in a cardiac journal, it provides useful information to non-cardiac anesthesiologists. Yet another review article. So the anesthetic management of patients with heart failure and LVADs is really quite basic. It's ASA monitoring and perhaps an arterial line, and if indicated, a pulmonary artery catheter can be inserted for continuous SVO2 monitoring and an indication of global oxygen delivery. Intraoperatively, the monitoring of the LVAD function, if you suspect ventricular suck down or something like that because of hypovolemia, might require the use of transesophageal echocardiography, but not necessarily routinely. Well, this is the end of this podcast, and I apologize for not giving you a list of how to give anesthesia for patients with heart failure or LVADs, but this is the nature of these kinds of patients, and it requires your clinical acumen and skills applied to an individual patient in order to provide safe care with good outcomes. Thank you very much for your attention.